Mm-hmm.
Hello, everyone. My topic was PFCN, the final solution for 31A3 trochanteric fracture, when and how to augment. My name is Hui Liu. I'm from Dongnan Hospital of Xiamen University. It's the base of a double engine. As we know, the trochanteric fracture necessitates the mechanical stability. For this stability, allowing the patient to early mobilization. But in the clinical scenario, the stable fixation tier to fracture union is the keystone of the long-term good clinical results, which need our to do good selection of the implant, good reduction, and good surgical techniques for implant placement. This is a paper review from injury in 2007. They list 8 points of the risk factor for unstable trochanteric fracture failure. We found that there are 4 points. They talk about the A3 fracture. It's subtrochanteric extension, reverse oblique fracture patterns, burst lateral wall, posterior wall fracture, and coronal split. They belong to the A3 fractures. But what is the specific features of a 3.3 fracture? We can see these photos. It completely lost the medial support, femoral calcar, and the lateral tension band, lateral wall. First, we will begin from the medial support. There are many clinical papers and biomechanic papers told us if you have a good reduction of the medial support, less trochanter, you will increase the fracture stability. Now we move to the lateral wall. In fact, the lateral wall concept came to us in 2014, especially in the International Orthopedic Journal. Doctor had defined it. It's the tangent line of the superior femoral neck and the superior lower femoral neck. Dr. Ma defined it as the varus lateralis reach to the plane of lateral trochanter. But what is this concept related to the clinical? Before these concepts come to us, in 2007, Dr. Palm, he told us some clinical implication for the lateral wall for extramedullary fixation. He found that during the 2.2 and 2.3 fracture surgery, if you use the DHA fixation, may cause iatrogenic lateral wall fracture for the very thin wall of the lateral wall in this kind of fracture. So you choose the intramedullary fixation may be better. Another doctor, Dr. Gupta, he told us, if we can put in a plate, maybe in theory, it can provide lateral buttress for the proximal fragment, just like this TSP plate. Also, some screw in the TSP, it can add some anti-rotation role while it's permitting sliding collapse at the same time. But what is the role for the lateral wall for the intramedullary fixation? We all know that the nailing fixation substitutes the medial supporting structure, but the nailing supply effective lateral stability? It seems not really. In literature, failure rate of the nailing fixation in the unstable trochanteric fracture is 12.7% up to 27%. Most caused by absence tension band. For the deformity, most is the varus deformity. So maybe we need to do a more specific or concrete subclassification for the A3 fracture. Bob Harker, he proposed a modified OTA classification for A3 fracture based on the CT reconstruction. A-type is the lateral wall fracture as we see on the lateral CT. Type B is a post-wall fracture and also some comminuted, but the fragment doesn't dissociate and displace it very large. Type C is the burst lateral wall fracture with the post-wall and the medial column. The fracture fragment dissociates and overall comminuted. Some company, they told us they can give us the most powerful products for A3.3 fracture. For they have two screws, they can supply us rotation stability. Also, some paper told us this kind of products can reduce the non-union 73% and 69% implant failure. But if the screw doesn't cover the fracture line, maybe it's not really reconstruct the lateral wall and the lateral tension bands. So which kind of subgroup in A3.3 need augmentation? First, if there is a free bone fragment and a transverse fracture line across the lateral femoral wall, there is more than 10% in this paper, they have implant failure. Number two, if the lateral wall fragment displays very large, you also have high failure rate. In this paper, they measure an angle called tilting angle. That's the line between the tilting, they called it tilting angle. That's a line between the lateral wall and the lateral ridge of the nailing. If this angle bigger than the 14 degree, you may have a not good fracture healing. Just like the fracture X-ray show in this paper, we can see if the displace is not very large, they can have a very good spontaneous reduction. But if the tilting angle bigger than 40 degree, you maybe not acquire a spontaneous reduction. So that's meaning the reduction is the same importance as the fixation method. The third, if the fracture line extended to the diaphyseal and also have the huge key fragment, we need to do augment, such like wine, to have a good reduction. So, as we know, we have some tools, screw, wine, and plate. You can use as tension band plate or reduction plate. But why you choose one of them? And is there some evidence for them? We recommend you can use these three tools according to the Barber-Harker modifying OTA classification. If the lateral wall fragment is very small or incomplete fracture line and your reduction well, you can use the screw. But if there's a coronal comminuted and the short length of the lateral wall fragment, no anchor for your plate or screw, maybe use the wine is better. If the lateral wall size is bigger enough, you can put in the single cortex screw and it extended to the diaphyseal. Maybe this kind of C-type, you can use the plate. First, we come to the screw. This is a paper from the CCOT. There are 45 A2 and 37 A3 fracture, but after the screw or wine augment, there's only 6 patients show more than 5 degree varus angulation. No case of the screw cutout. But in the literature, the cutoff rate of school is up to 2.5%. So next we comes to the B type. You can see the free fragment is very shallow, so you cannot put in a screw or plate. So you can use the Y as a reduction Y. After the Y reduction, you can put in nail. Another example, it's a very simple A-type fracture, but the reduction is not well. But we want to use the Y to have a good augment. It's a tension bind. The proximal, you pass through the gluteus medius. The distal, you pass through the lateral trochanter. This another example for the Y augment. You can also put in two Ys. One is for the post wall and the lateral wall fragment. The other for the lateral trochanters. This is our patient. It's involved the post wall and the fragment is very shallow and it's very long, extending to the diaphyseal. As we can see the CT, there's no large place for you putting in a single cortex screw. So we use the minimal invasive Y inducer. You put in the reduction Y. After the Y, you can nail in the fracture. You can see it's a very good implant fixation. But how about the augmented clinical result? This is a comparative study. There are 74 versus 70 cases with or without augmentation. You can after augmentation, you have sooner healing time 3.6 versus 4.1 months, and also the complication rates like screw cut out or back out and non-union was lower in the augmented group. As we know, in the distal femur fracture, we often use the plate. For plate-assisted reduction, they add rotation stability, also the plate feasible for nailing. Why not? We have a contrary thinking. Why not we use the plate in the proximal femur? You can use plates in a transverse as a reduction plate. It's a comparative study. The single PFNA group have the mechanical complete rates about 14.3%, but if you add a little plate, the screw back out only 2.9%. If the fragment is longer enough, you can plate in a plate or screw in this fragment. You can put in a plate in longitude. And also, this compare with the pine wine, they show a better clinical result and the fracture healing. So this is our cases. It's a 3.3 C type coronal split fracture. We do this surgery in a lateral position. After we do a minimal incision, a single cortex reduction plate was for reduction the fracture. After that, we'll put it in a nail. You can see after 3 months, the fracture healing not bad. So we need take some message. 31A3.3 was not a simple fractures. Before the surgery, you need to do the CT to evaluate the lateral wall fracture type and the displaced extent. For this, can decide, do you need augmentation? Third, the augmentation indication means the free lateral fragment, especially they displaced, split, and extended more. That means the B or C type. Also, we need to remember, we need to do a minimal invasive reduction for the fragment, and you use some minimal invasive techniques, not to the ORIF. Some complex fracture maybe need minimal incision, but are not you use some KY to do some, for some very simple, you can use the KY, but it's very complex. You need to do a small incision. Finally, in this kind of fracture, only we have a very good or concise evaluate for the fracture type and a minimal invasive reduction, we will have finally biological and mechanical fixation philosophy combined clinical result. Just like we say we begin, we need a long-term goal to acquire a fracture healing. That's my report. Thank you.